In 1977, Soviet physiologist Yakov Kotz made a bold claim. He reported that applying a specific neuromuscular electrical stimulation protocol generated 30 to 40% strength increases in his elite athletes. Based on those numbers, this protocol, dubbed Russian current, was exported and quickly became a staple in physical therapy clinics worldwide. Today, there is a clinical paradox. Russian current is prescribed for diverse conditions, from post-ACL reconstruction quadriceps atrophy to postpartum diastasis recti abdominis. Diastasis recti abdominis is a condition where the abdominal muscles separate during or after pregnancy. Yet, despite its widespread use, it frequently fails to deliver the strength gains Kotz originally promised. The core reason for this failure is application error. Clinicians frequently misapply Russian current as a passive set-it-and-forget-it modality. Achieving supraphysiological torque requires a precise understanding of the waveform's electrophysics, exact parameter dosage, and the strict mandate of concurrent volitional muscle contraction. The primary hurdle of transcutaneous electrical stimulation is the skin itself. Standard low-frequency currents encounter high skin impedance, which triggers sensory nerve discomfort and limits the amount of amplitude you can actually deliver. The Russian current architecture solves this using a 2500 Hz carrier frequency. This high frequency effectively lowers skin impedance and creates a painless sensory nerve block. But a continuous 2500 Hz wave does not trigger optimal tetanic muscle contraction. A tetanic contraction is a sustained, forceful muscle flex evoked when the motor nerve emits action potentials at a very high rate. At 2500 Hz, the wave strictly serves as a carrier mechanism. To get the muscle to fire, the machine uses burst modulation. It takes the continuous sine wave and chops it into 50 distinct bursts per second, creating a 50 Hz frequency. The clinical parameters of these bursts are precise: a 10 millisecond burst duration, followed by a 10 millisecond off gap. This creates a 50% duty cycle. This dual frequency geometry is engineered to do one specific job: to sneak massive electrical energy past the skin's pain gate so it can directly access the motor nerve. Once that waveform breaches the skin, we transition from physics to biology at the muscle fascicle. Normal voluntary muscle recruitment follows Henneman's size principle, activating small, slow type 1 fibers first. The 50 Hz burst of Russian current hijacks this biological system. It forces synchronous depolarization of the fast, powerful type 2 motor units, bypassing type 1 entirely. This generates an immediate tetanic contraction, producing torque that exceeds normal physiological firing capabilities. But this biological hijack comes with a cost. Forcing synchronous type 2 activation creates massive, rapid, localized fatigue. While the current forces the muscle to generate immense force, it creates an unsustainable metabolic demand at the neuromuscular junction. That demand must be actively managed by the clinician. This chart shows the inherent limitation of stimulating type 2 fibers with medium-frequency alternating current. If applied continuously, the torque spikes initially and then rapidly plummets. To prevent this crash, early researchers designed the classic 10-50-10 protocol specifically as a fatigue management system. The timing dictates exactly 10 seconds of active tetanic contraction, followed by 50 seconds of off time. This sequence is repeated for 10 cycles. That 50-second rest is not a manufacturer's suggestion. It is a non-negotiable biological requirement for the neuromuscular junction to repolarize. Ignoring the off-time interval destroys torque output and exhausts the muscle. This explains exactly why passive, continuous applications of the current fail in the clinic. Modern neuromuscular electrical stimulation, or NMES, machines allow clinicians to move beyond the rigid 10-50-10 protocol using expert modes. A randomized controlled trial published in PLOS One evaluated quadriceps muscle torque utilizing these specific expert modes, allocating subjects to either an on-to or rest protocol. These modes allow the user to modulate the burst frequency and duty cycle, specifically during the inactive off-time phase. Frequency serves as the primary regulator of muscle fatigue. Manipulating it allows for tailored physiological recovery between contractions. By manipulating the duty cycle through these expert modes, The physical therapist gains precise control over the dosage of neuromuscular exhaustion, pacing the treatment to the patient's individual tolerance. There is one ultimate rule for Russian current efficacy: the volitional mandate. The electrical current must be superimposed onto voluntary isometric, isokinetic, or isokinetic contractions to be effective. Isometric exercises involve muscle contraction without joint movement, while isokinetic and isokinetic involve actively moving a load through a range of motion. Clinical data from anterior cruciate ligament reconstruction rehabilitation shows that applying Russian current during volitional activity accelerates skeletal muscle activation. This chart shows the exact outcomes. Patient scores on the lower extremity functional scale improve dramatically, from a baseline of 32, indicating moderate limitation, up to 64, indicating minimal limitation. We see similar functional data regarding postpartum diastasis recti abdominis. Combining the current with active transverse abdominis activation pulls the rectus bellies together, effectively reducing the interrectal distance, the physical gap between the abdominal muscles, from 3.5 fingers down to just 1 centimeter. Without concurrent volitional load, the electrical stimulus successfully depolarizes the nerve, but it fails to translate into functional mechanical strength adaptation. This data brings up a modern clinical controversy. Is Russian current still the absolute gold standard for generating torque? A randomized controlled trial by Ballou and colleagues compared Russian current directly against other waveforms using equivalent stimulus parameters. This chart shows the maximal voluntary isometric force outputs. The data proves that interferential current and burst-modulated biphasic pulsed currents can actually yield greater raw force than standard Russian current. While interferential and biphasic currents might produce higher raw torque in specific settings, Russian current remains a highly proven clinical tool when dosed correctly. Success dictates 3 strict requirements. First, utilizing the 2500 Hz carrier and 50 Hz burst architecture to bypass the skin and depolarize type 2 fibers. Second, enforcing strict rest intervals, using the 10-50-10 protocol or expert modes to manage inevitable neuromuscular fatigue. And third, superimposing the current onto active volitional exercise. Russian current is not a passive cure. It is a highly specific electrophysiological tool that demands precise parameter dosage and active patient participation to rebuild atrophied muscle.